So, welcome everyone to CICMH's June webinar. It's on increasing capacity to support students with an eating disorder. So for all of you who are used to a lot of our webinars, this is our first time on Zoom. So it's going to be a little bit of an interesting ride because I'm not too familiar with it yet. Everyone should be on mute, but if you're not on mute, I would kindly ask for you to mute yourselves. During the course of the webinar, if you have any questions or if you just want to engage with the presenter or other people in the webinar, there should be a chat function that allows you to chat with everyone. Okay, and this webinar is being recorded, so a recording of the webinar as well as the slides is going to be made available on our website, and an email with a link to that is going to go out tomorrow. So with that, I'm going to pass it along to our presenter, Ari Maharaj, who is the Outreach and Education Coordinator at the National Eating Disorder Information Center. Take it away.
Thank you. And I'm going to share my screen for folks. Cool. So hi everyone, and thanks Perlin for the introduction. My name's Ari Maharaj. I am a registered psychotherapist qualifying here in Ontario, operating out of a low-cost practice in the city of Toronto called Hard Feelings. And I'm also NEDIC's Outreach and Education Coordinator, where I have the privilege of doing prevention work in eating disorders as my full-time job. And for me, the two, service delivery and prevention, have always really been interconnected. And I hope you all will get that perspective from me throughout this webinar. I also have the privilege of having worked in two of Ontario's larger post-secondary campus counseling centers. So I'll try to bring that experience too, and you'll probably laugh at some of the analogies and data that I cite because it'll be really common experiences for many of you working in the sector. I think I'd be remiss if I didn't start first with just an acknowledgement about what's going on with respect to COVID-19, what's going on in the US, Canada, and globally with respect to police brutality demonstrations and conversations that we're having about systemic racism as a community. And this is a quote from Sonia Renee Taylor, who identifies herself as a queer Black woman who we, NEDIC, brought to Canada and Toronto in 2019 for our conference, and she spoke really wonderfully about many of these topics. And I kind of want to acknowledge for the topic we're talking about today, the field of eating disorders is historically and chronically very white. And this means that Black folks and other people of color are both less likely to receive appropriate care from professionals who understand the ways in which race, identity, and health intersect, but also seek help for these same concerns that everyone has. We know that health is correlated with many factors, and the experiences of racism and intergenerational trauma, including police brutality, can have powerfully negative impacts on health. Our organizational mission here at NEDIC involves supporting individuals in achieving health, and whatever that looks like for that person's individual situation. And so we must consider the social factors which can deny those same folks health. Most of what we consider too evidence-based practice is based on research done mainly on young college-age white folks, primarily from the northeastern United States. And even discussions we have on cultural competency on our campuses bring up questions about competency for whom, thinking that if we just studied people's experiences and a couple hours of training here and there, that the thoughts, feelings, and behaviors that we might have that could be steeped in racism and supremacy would just disappear. And I think we all know that that isn't the case. In eating disorder prevention, we often say that all bodies are good bodies, and we firmly believe that to be true. But at the same time, beauty ideals rooted in white supremacy impact whose body is perceived as good and whose body is perceived as a threat. Body positivity, of what's known of that in an online movement, exists because of activists who are often fat Black women. Pride Month, which I'm honored to hold this webinar in, happy Pride to those folks, is because of riots started by trans people of color like Marsha P. Johnson and Sylvia Rivera. So in all the things we're going to talk about today, from recognition, responding, and referring, we need to commit to reflection and lifelong learning about how these issues impact our students on campus. So I'm going to move into the agenda for today, and I know that there's a slight lag between Zoom, so I hope all of you are still able to follow. And we're really going to be talking here about recognizing, responding, referring, and reflecting. And I'm very much borrowing this sort of from the Center for Innovation in Campus Mental Health's own More Feet on the Ground project that some of you may be familiar with, and we often get a lot of student leaders to do. I know all of you are campus health professionals or student service professionals, but I think these same 4 principles can really reflect in all the ways that we're doing. And I'll organize the presentation that way. As always, if you have questions, Perlin's going to be monitoring in the chat. So please send your questions there, and we'll make sure that there's time at the end for us to address it, whether it's on some of the equity-related concerns I first mentioned or about anything in this presentation moving forward. So a little bit about us. NEDIC was founded in 1985, and we're mainly known for staffing Canada's English-speaking toll-free helpline for eating disorders in the country. We also operate a national treatment and support database with over 700 plus eating disorder informed service providers that you're gonna get to learn how to use today. We provide information and education on eating disorders. And while I think we could have absolutely had this webinar totally focused just on eating disorder prevention on our campuses, we're really gonna focus today on improving all of your capacity to understand what an eating disorder is and some initial steps just to kind of get us all on the same page. Because I think before we ever jump to prevention, it's really important to know that prevention starts with all of us, and we need to make sure our knowledge is at a level where you feel comfortable with at least engaging in this material. Eating Disorder Awareness Week from the first week of February is a really good reminder every single year to kind of commit to learning more about eating disorders and supporting people who experience that. And that's another thing that we run. And before we begin anything further, I think it's really important to know that recognition really starts with learning from folks with lived experience. As I kind of touched on earlier, eating disorders is one of those issues that are chronically understudied, and especially from folks with lived experience, let alone folks with lived experience from underserved communities. It's something that we don't really hear that much about. So I have a video here from a narrative talking about someone's lived experience. The audio, when Perlin and I tested it, was crystal clear, so I hope that's the case for you. It's going to be a little bit out of sync with the video, and I hope that all of you are able to have the patience to kind of stick with it, because it's something I still thought was really important to include. So I'm going to let that play.
Heaven forbid a man deals with something that a woman does. You know, this idea that like if it's a woman's disease, you're not as much of a man for having it. There were many different steps that turned what were smaller, unhealthier behaviors into something that was out of control. I think this is common for people with eating disorders is one day they might have the realization that, yeah, this is an eating disorder, but generally at that point, they've probably had it for quite a while. My earliest memories of what I would consider to be disordered eating, disordered body image started probably as early as middle school. Looking back, I would say what I was doing was a lot of chronic dieting. It was in university that sort of spiraled into exercise compulsion. And from there, some behaviors that I think people would associate with anorexia, a lot of periods of starvation, and then more behaviors that people would associate with bulimia. So a lot of binging and purging, calorie counting, being obsessive of tracking my food, all that sort of thing. When I physically started to make myself purge, that was when I knew it had for sure crossed a line into something that was unhealthy. Before, I think I could sort of kid myself that the excessive exercise was healthy, even though I didn't enjoy it. When you're actually making yourself purge, I think it's sort of hard to kid yourself that there's something health related about that. For me, I think it was a mental health issue. It's not actually about the food. It was an intense fear, an intense anxiety where I felt like the only thing I could do to make that intense anxiety go away was to get rid of it. People assume that, specifically that anorexia is a white teenage girl's problem. They don't realize that body image, eating disorder issues, that there's all different kinds of them, and that it doesn't matter your race, nationality, gender identification, sexuality, none of those things really matter. The other men that I've met who were seeking out help, I remember like repetitive themes of them feeling like when they talked about it to other people, that it wasn't really recognized. Even in school for health and fitness, if one of the female athletes that was in my program had dropped the amount of weight that I did, I think it probably would have been addressed in that way a lot more and a lot quicker. I think more than anything, Sheena's place normalized my experience. It was like, hey, man, you're not the only person who deals with these issues. You're not the only guy. What I've said to people who I've worked with who struggle with eating disorder behaviors is try to imagine a life where body image, food, exercise, where those things aren't a problem for you. Where if these things weren't consuming what you were doing, what you might do with that life. That was my motivation for getting better. But there were many days when I was actively pursuing recovery, whatever you want to call it, where where I struggled. It felt difficult, and I felt like, okay, I've made these strides. I'm not doing these select behaviors anymore, but I'm still dealing with this anxiety. Like, am I ever going to be able to just exercise or just eat a meal without it being an issue? And I would say that probably lasted for a good, at least a year after I started getting help. I would still have those periods of fear that it wouldn't go away, but it did. I think it does. I think at some point you can make the choice to say, I'm worth getting some help for, like my life is worth pursuing help, deciding to try to get better, but it's not as easy as just saying, screw it, I'm gonna eat dinner. There was a lot of goal setting and there was a lot of failing at those goals, but the biggest thing is not beating yourself up. I think that just throws you back further.
So that was a video that was created for one of the aforementioned Eating Disorder Awareness Week experiences. And I think I chose that specifically because Jay identifies as a man with an eating disorder, and I think it's an atraditional experience for folks. But also because of, I think, the nuance that Jay talks about with respect to the eating disorder, that often we think, because it's in the name, eating disorder, that it's completely all about the food, that it's only a certain kind of person, and really none of that is the case for a significant majority of the folks that are there. And yeah, I hope we keep that perspective in mind, and I'll try to keep those reminders in mind throughout our time today. And as we talk about this, I think we're going to talk about it in the sense of eating and weight concerns and as a continuum, because as you can see on the very right here, eating disorders, the diagnosis is something that's very severe and is something that's a concern. But a majority of the time, what you're going to be spotting potentially in your campuses are what falls into this box of disordered eating. And you'll see a bunch of the words here in this box. The more that you identify, the more that I think of it as like flags. And the more flags you have, the maybe more likely you're going to be closer to maybe having an eating disorder than not. Flags like a preoccupation with food, weight, or shape, striving for perfection, being on and off diets, compulsive eating, excessive exercise. We're going to talk about some of these. And I also think it's important to keep in mind the positive sides of how we feel about food, weight, and shape. That's an acceptance with our bodies. That's a trust that we have in our bodies. And that's a flexibility around food. Because everyone has some foods that they don't like, and everyone is a picky eater in some way, shape, or form, and everyone has some bad body image days. I think that's something that's really normal in a way that we can resonate with folks who experience this. But reaching a state of body acceptance means that you really do understand that your body is the vessel you go through life in, and it's something that you want to make sure you're not harming because it's helping you do what you need. And having trust in your body is something that's also, I think, easier in a social context where people don't see your body as a threat. And again, when we think about what's going on in the world right now and has been for a very long time, especially for our Black and Indigenous colleagues, I think it's a lot harder for them to maybe reach a state of body acceptance and body trust in this sort of social atmosphere. So again, that's something we don't traditionally talk about in these concerns, but I think it's something we have to make sure that we need to do a better job at, because I think then taking an individualistic approach to this only does a disservice, if that makes sense. What do these think, feel, and sound like when we're talking to students? And I broke it down in this way because I kind of thought that all of you in some way, shape, or form have heard about cognitive behavioral therapy, especially in relation to mental health. And this is a really common way to break that down. And we'll start on the very left with those thoughts, because thoughts are thoughts. You have thoughts, I have thoughts. We have millions of them throughout our lives, if not billions. And they don't necessarily mean that just because we have a negative body-related thought, like I don't think my body is thin enough or muscular enough, isn't necessarily a bad thing, because I imagine all of you have thought that at some point in time about your bodily experience. But it's when that thought kind of becomes a hot thought or a sticky thought, and it gets attached to a feeling, especially a negative emotion like shame or guilt or anger or sadness, that becomes a little bit more sticky and a little bit more grounded and a little bit more hard for folks to not get stuck in the thought. And then especially when we move to a perception, both of yourself, that I don't like what I see in the mirror, but also that from others, that others maybe are telling me that they don't like what they see, whether that's a parent, a family member, a loved one, my campus president, my professor, etc. That makes that thought even stickier, because now the feeling is grounded in a perception and people can believe that perception to be true or not. And it's usually from here that it gets anchored in a behavior, like I will weigh myself, exercise more, or eat less. And that's when we generally spot it. That's when we get worried. And ultimately, I think if in a society where we have really strong eating disorder prevention, we start to notice it in the feelings and perceptions we're hearing in conversation from our students, from our colleagues, from our classmates, that we're starting to hear emotion and we're starting to see perceptions of that from themselves or other people that are really anchoring in that, and we're getting them help then. Because when we get to a behavior, that's when we get extra worried. And this is to touch on identifying disordered eating, because often I think when we take a recognize, respond, refer approach, sometimes we can be extra judgmental with our eyes by accident. And it's really important when we think about recognizing to remember that non-judgment is a really key part of that recognition, because especially with eating disorders, and you heard Jay say this, it's often thought of as a thin, young, white woman's illness, when really it isn't. Even in these images, like we often think of eating disorders of people having a certain body type, when really they don't. There can be people in quote unquote normal weight bodies or quote unquote overweight bodies that experience an eating disorder. And our eyes love to play tricks on us, especially with how visual sometimes we think internally an eating disorder can be. So it's really important to keep that in mind when we're thinking of recognizing an eating disorder. And as we start to look at some warning signs, I want you to look at them not from the approach of judgment, but from an approach of education, because when we notice these things, we're not probably going to have a conversation with a person about these things because they're likely not going to be ready for it yet. But it's for us as a helper to keep that in mind, what we're noticing, and potentially as we notice more, we'll talk about strategies to have a conversation with a loved one about it. But I don't want anyone to take this and be like, well, it looks like you're following strict food rules and therefore like something is wrong, because that's not the approach that we kind of want to take, and that's often just going to scare people off. Some of the things that I've bolded here are not bolded based on evidence, but more so my anecdotal experience of working in campus counseling centers. What are the things that I started to notice a bit more as someone on the ground like many of you? So all of these things are common behavioral warning signs. But to me, the following of strict food rules, that hearing negative conversations around someone's weight, shape, or size, and that weight or food control really determined how that person felt about themselves, their character, their well-being, that's when I started to, I think, get extra worried. Here are some more. Some of these sound like more so like traditional eating disorder warning signs, like frequent visits to the washroom after eating. But I want to touch on the ones that Jay mentioned here too, like following a strict exercise regimen and turning to health supplements to increase bulk or decrease weight. Often our conversations around health and fitness can be especially worrying because are we engaging in health behaviors? Are we engaging in fitness behaviors to get our body a certain way? Or are we engaging for them for the social benefits of well-being? And the difference between those two things are really important, because if it's for physical benefit, if it's for appearance, if it's for others, if it's to get the body that you want, and it's so strict that you're potentially exercising so much that it's through injury or through pain, that's when exercise can be more so a compensatory behavior around larger body image concerns, because often exercise can be a way that we feel control about our physical health and our mental health, when in a university and college experience, so much of what we're experiencing is out of our control, whether it's the grade that you had or the amount of coursework having in that certain time. That student is often not really in control of that, but they are in control of an exercise regimen, and potentially that's a way that they're regaining control. There's also some physical warning signs, and I'm touching on this because we'll touch on it a bit later in the respond section, but things like feeling cold constantly, or dizziness or fainting, or for women identified folks, a loss of regular menstrual periods. Those are really concerning things from a physical health standpoint, because an eating disorder can affect every body system that we have. And often we need consultation with medical professionals, whether they're on our campus or not on our campus, and we'll talk about finding them later, because these are things that they need to track. And it's really important to note here that a lot of people with eating disorders, unfortunately, have very negative experiences with healthcare professionals. And that's mainly because of lack of education. So in Canada, medical professionals get on average, less than 5 hours of eating disorder specific training. You all are getting a 50-minute webinar right now. And although our content is probably pretty different, that's a bit jarring, because I don't think you'll necessarily feel extra prepared after these 50 minutes. And I don't expect a doctor to be extra prepared after 5 hours or less. So we've developed at NETIC, in conjunction with another organization that we'll talk about later, a resource to help guide these conversations with medical professionals to lead to action for these communities, because unfortunately, clients and students with eating disorders have had to take on a lot of advocacy themselves. So I've gone this far without giving you a definition, partly on purpose, because I wanted to communicate nuance. But if I am going to give you a definition, this is the one that we use, which is persistent disturbances in eating and eating-related behaviors that negatively affect one's physical health, mental health, and psychosocial functioning. Key words here being persistent, something that's happening over a longer period of time. It's a disturbance to that person's life, and it's really impacting their physical health, mental health, or psychosocial functioning. And eating-related behaviors don't necessarily just have to be around the food experience. So it can be around weight and shape, and the way in which we're controlling eating and compensating for eating around weight and shape-related concerns that we're having. I was going to make this a poll, but because this is the center's first time using Zoom and I didn't want to necessarily hassle all of you with it, I'm going to ask you to reflect on this question. So I want you to reflect on whether you have actually heard of any of these 5 eating disorder diagnoses in light pink. If you've heard of them, yay for you, bonus points for you, because many people have not heard of them. Many people just know of these ones in dark purple, anorexia, bulimia, and binge eating disorder. And I want to touch on here that a diagnosis is a medical label that medical professionals primarily use to communicate about illnesses, but for things like eating disorders and many other mental health conditions, as some of you may know, what it takes to get a diagnosis is a process in and of itself. And there are many communities, especially those from underserved communities, who don't receive a diagnosis for whatever reason. So again, we are more going to be talking about this from a disordered eating lens, something that doesn't necessarily need a diagnosis. But I wanted to let you know that there are many diagnoses here outside of the main three that people are affected with. Binge eating disorder, for example, is one of the ones that's the most stigmatized, but it's also one of the ones that's the most common. And people experiencing binge eating often feel so much shame about potentially being out of control, and often find themselves in quote unquote larger bodies and experience that shame societally too, about like, get your lifestyle together, or get the way you're eating together. So it's really important to acknowledge that if you have a student confiding in you about binge eating, that it was probably a really, really hard journey for them to even get to that point. And it's really important that we acknowledge and validate that from a place of education, that like what they're experiencing is one of the more common eating disorders, and you know of how much stigma and shame people have about it. OSFED, other specified feeding or eating disorder, is the other one I'll touch on, mainly because I had a client once at a post-secondary campus who had this diagnosis, and they got so caught up with having other in the diagnosis that they thought that what they were experiencing was less severe. And they thought like there's no reason for them to go and get help because there's so many people with actual anorexia who needs support and not me. And really the other is just because a medical professional thought that they had some criteria of some of these main three diagnoses, but not all of them. So they received this other diagnosis, but maybe didn't take the time to communicate that with that client. And it really started to impact their psychology, the way they thought about themselves. So when we hear labels like this, it's really important to keep that in mind. Those two, OSFED and UFED, in the old DSM, DSM-4, and TR, were previously known as EDNOS, eating disorders not otherwise specified. And if you want definitions for these, I'm going to show you how to get them by the end of the presentation. There's also some informal or unofficial diagnoses that I'll touch on really briefly because I think they bring up important points. Orthorexia is really this fixation with clean eating, where the content of that food being clean or eating correctly really takes up a lot of someone's experience. They really want to only eat quote unquote healthy food and like cut out any quote unquote bad food. And really this moralizing of food that we do, I don't know how many of you in the pandemic especially have ordered good food boxes, those delivery food boxes that we get, and it's labeled a good food box as if the food there, eating that is a good thing. And those labels can really do something to many people's experience of food, and especially folks experiencing an eating disorder. They can get really tied in with what they're experiencing. Anorexia athletica is compulsive exercising. And again, we hear of exercise as a way, not from a mindful, joyful movement for social benefit, but a rigid compensation, exercising through pain, exercising as a coping behavior. That's really worrying. And then diabulimia is worrying when folks with primarily type 1 diabetes purposefully restrict insulin, which they need to regulate their blood sugar levels in order to lose weight. And I want you to think about potentially the people in your life that may have diabetes and the amount of comments we give those people about their lifestyle and the bodies that those people often live in. And imagine what they may experience if they have diabetes and an eating disorder. So again, another concern that I think we need a lot more training and stuff on, and we have a specific webinar on our website on diabulimia. And I think as hopefully all of you are getting beat over the head with this on a regular basis, that a lot of mental health experiences coincide with other mental health experiences. For eating disorders, for example, depression and anxiety are really common, but so too is trauma as a cause. Self-harm is a really worrying one, where people who experience an eating disorder in their lifetime are more likely to attempt suicide than those who aren't. People with anorexia are 5.4 times more likely. People with bulimia are 6.3 times more likely to attempt suicide. 1 in 5 deaths from anorexia nervosa are as a result of suicide. So as our campuses are thinking about suicide prevention strategies and self-harm strategies on a whole campus approach, don't forget people's experiences potentially with an eating disorder, and ask those questions among your committees or seek out further education from resources like us, because it may be really important to consider those folks if they're experiencing that at a statistically higher rate. Substance use is another one that I'm going to talk on, because addictions and eating disorders, there's many, many shared characteristics, whether it's cravings, secretiveness, social isolation, being really difficult to treat, being life-threatening, high relapse, but also from a risk factor perspective, they both occur mainly during times of stress, common family history, brain chemistry, often low self-esteem, often a history of sexual or physical abuse, often a lot of neglect at home from parental experiences or from peers, a lot of bullying, and they're both stigmatized in the media. And maybe all of that helps explain why 35% of people experiencing addiction have eating disorders, compared to 3% of the general population here in Canada. Both are often a form of coping and a struggle for control. And if we think about eating disorder as just a way of someone coping with the life that they've had at this time, you can think about substance use and addiction in a similar way. So this is by far the most common question that I often get when I'm out in the community. What causes an eating disorder? And I think sometimes this can turn into a blame game and a history searching for a lot of folks. But I think taking a biopsychosocial approach, which is something common among other mental health conditions, is something that's really important. Anorexia in particular has a higher genetic heritability than schizophrenia and diabetes, but we hear a lot more about those two illnesses and their genetic component. The psychology behind it is often around low self-esteem, body dissatisfaction. Perfectionism is the key one, especially in some studies. We hear about folks with experiencing an eating disorder really not having it impact their academics. These are often really, really smart, straight A, 3.7, 4.0 GPAs. And they're so driven and so smart, but are also applying that perfectionism also to their body and the way they look, or the way their food experiences or their exercise. Then there's also social risk. So exposure to weight stigma, exposure to negative media messaging, like on social media, especially on a platform like Instagram or TikTok now. Exposure to parental communication that was really negative, or peer-related communication that was really negative. It's usually a combination of these three things, these three factors that cause an eating disorder. And we really want to strike the message home that people of all ages, identities, socioeconomic statuses, genders, etc., experience an eating disorder. They're as diverse as the people they affect. And from a stats perspective, around 20% of those living with an eating disorder are boys and men. Again, disproportionately affecting women-identified folks, but really important not to forget those folks. Similar across some levels of socioeconomic statuses and among non-white ethnic and racial backgrounds. But in particular, I think one flag that's really worrying for me is in a large survey, N above 1,000, of LGBTQ plus youth in the United States, 54% of respondents indicated that they had already been diagnosed with an eating disorder. We touched on earlier how tough it is to get a diagnosis and what that entails, and the fact that 54% indicated that they had already had one is really worrying. I think especially, I'm also really worried about trans men, because the report here was 71% of trans men indicated that they had already been diagnosed. And if you think about non-cisgender, non-heterosexual experiences, how much of that for safety, but also for expression, has to do with a physical appearance. Many trans folks change their appearance and want to present a certain way for passing purposes, which makes a lot of sense. Many non-heterosexual folks express their sexual identity in a way that is physical. And so it's no surprise to me, and I'm not really shocked. I'm saddened by how prevalent it is, but I'm not really shocked by it if you know anything about these communities, about how much they may be engaging in food and exercise and body-related change behaviors to present their experience, especially if they're in a non-affirming, non-supportive environment. So this is where I said I hope I would have some chuckles, because I wouldn't be a campus mental health professional if I didn't know about the NACHA data. So this is my attempt at citing this for you. And also, I think from an institutional perspective, any folks attending from administration or management, really important to keep this in mind. I was really saddened and disappointed in the fact that in the executive summary report for the NACHA 2 in spring 2019, there were only 2 mentions of eating disorders specifically. They were that in the last 12 months, 1.9% of respondents identified that they had been diagnosed or treated by a professional for anorexia, and that within the last 12 months, 2.5% of respondents reported that their eating disorder affected their individual academic performance. That's it. Those are only 2 mentions in the executive summary, and let's be real, we know how many of us just read the executive summary and move on. And if we just did that and didn't look deeper into the data, we would miss a lot about eating disorders and about that experience. And I think from a recognition standpoint, but just a standpoint that is systemic, if we aren't measuring eating disorders and we're not making that clear, how are we ever going to know if it's an issue? And how are we ever going to create health promotion programs and campus counseling services that can reflect how prevalent they might be on our campuses? When you dug a little bit deeper, you started to see in the reports, and all of this is from the Canadian reference group data only in spring 2019. The question here was, have you received information on the following topics from your college or university student services? No, for eating disorders, 78.7%. So more than 3/4 of folks that they hadn't ever received it. It's not the case for depression and anxiety, not the case for drug use. It's interesting that nutrition, I think, is in general, a lot of folks, we maybe have some gaps here around eating and food related experiences that 60%-ish of folks said that they didn't receive information on that topic on our campuses. And 47% said the same thing about physical activity. What's really important is the contrast to the bottom question. Are you interested in receiving information on these topics? More often than not, people wanted to receive information on eating disorders. Not to the same extent as depression and anxiety, and I think that makes sense given how much in the last decade we've grown as a country in talking about depression and anxiety. Still a majority. And it's more than drug use, which is really interesting because I know how many campuses, for example, are focusing on substance use prevention. And a lot of students have identified that they don't really necessarily, might not want that knowledge coming from us. There's probably a lot of other things there too. Interestingly, almost 3/4 of students said that they wanted to receive nutrition and physical activity information. So again, it's going to be really important that we're giving nutrition and physical activity related information that is eating disorder informed. And I really use that term intentionally and liken it to trauma informed, because I think we really have to take a similar approach. When you look back at how eating disorders globally affect mental health conditions and how much comorbidity there is, it's really important to consider that we as student service professionals, as campus health professionals, really need to make sure that we're informed here, especially when there's so little training available. Some other really interesting points. So this again is from the Canadian reference group data. How would you describe your weight? Generally speaking, 51% of respondents indicated that they think they're at about the right weight. 32% thought that they were slightly overweight. But when you think about folks actually trying to potentially change their weight, 50.1% said that they wanted to lose weight, despite folks thinking that generally speaking, they're around the right weight. If you add those who want to gain weight, because especially for men, the experience, especially for scrawny men, it's to want to gain weight. That's 60% of people that want to change the weight that they're in and in the body that they're in. And often that is through food and exercise. And dieting in particular is the biggest, if not the number one risk factor for developing an eating disorder. So the point here is that many people on our campuses experience food and weight related concerns. This next contrast is interesting too. So within the last 30 days, did you do any of the following? Exercise to lose weight. 48.8% of people said yes. They exercised to lose weight within the last 30 days. 38% of people said that they dieted to lose weight. So again, really large numbers. And I want to point that out because exercising and dieting may seem as things that are less harmful. There are things that in our society, and maybe even some of you that I'm getting you to reflect on in this presentation, may think that that's a good thing, to exercise to lose weight or to diet to lose weight. That's really different than what we consider traditionally in society about an eating disorder, about vomiting potentially, or taking diet pills, which are very low on our campuses. But these two things are really, really important to note. So I'm gonna let a video, again, there's gonna be a sync difference here, but I hope it still makes the point around why we have to go beyond weight when talking about eating disorders.
There's a big problem at the center of our research on weight and health. What's the problem? Well, picture a society made up of dogs. Let's say poodles are the bossiest group. They're the ones you see down at the doggy park barking at all the other dogs about how to live their lives in order to be healthy. But the problem is, poodles think that every other kind of dog is just a really big, a really small, or a really fat poodle, when actually the other dogs aren't even poodles at all. They're terriers, or mastiffs, or greyhounds, or labs. And all of the thousands of different dog breeds have different lifespans and different health risks. Each one has evolved to use food differently for different specialties at surviving. Some for staying warm, some for running fast, and some for being strong. They're meant to be different sizes and weights. So the poodles think the mastiff should lose weight, but a starving mastiff never becomes a poodle. The poodles don't understand that dogs come in many more sizes than they can imagine in their poodle-centric ways. So this becomes a problem when it comes to poodle science. When the poodles did their weight and health research and made their claim that lighter dogs are healthier and live longer, they weren't comparing thinner poodles and fatter poodles. They were comparing poodles and mastiffs. So the recommendation for mastiffs to lose weight is based on the false assumption that if all dogs reach poodle weight, then all dogs will have poodle health. But once again, a starved mastiff just isn't a poodle. This poodle science doesn't even test whether a starved mastiff lives longer than a mastiff who has enough to eat, because one would have to compare mastiffs who maintain poodle weight to mastiffs that maintain mastiff weight. And it turns out that starving mastiffs regain weight, which after all is a much better thing than starving. But the poodles can only see that regain as a failure of mastiff self-discipline. Look, poodles are great, but poodle-centric health policy is a nightmare. Good science tells us that it's better to recognize and respect the ways we're different, because how we're treated, having good friends, having access to decent food, a place to play, restful sleep, and medical care make a huge difference in our health and longevity for all of us, whatever our size.
So for me, one of the first parts of responding to a student potentially bringing up a concern is really checking our own biases and beliefs that we may have about food and weight and the way they impact health. Because unlike some other mental health conditions, almost everyone has an opinion on food and weight. And often they're very loud about sharing that in whatever platform they want to share that in. And it's really, really important because the first part of responding is identifying yourself as a safe person that someone would even disclose to and would feel comfortable sharing with. This is a slide that you all are going to have in terms of some misinformation about weight. Many believe that high weight is something as largely a result of poor self-control or weak willpower, and when it's largely genetic. Many believe that it's a key driver of health outcomes, when metabolic syndrome is more important, something we can't tell from our eyes as opposed to a number on a scale. And the social determinants of health, like they talked about in the video, access to housing, transportation, green space, etc., contribute far more to health outcomes than weight. And those who say people who are overweight need to go to the doctor, believing that they're going to have a negative experience is a key reason why many avoid healthcare. So we have to think about ourselves, get that critical awareness that's able to challenge some of the assumptions that we are all given socially about food and weight and their link to health. And we really have to value people's lived experiences with these issues and engage in self-care for ourselves and our own opinions, but also be able to apply that for others. Because I think we kind of want everyone to get to a space where they can eat in a flexible manner that works for them. There's no one sort of way to eat. And we want the same thing for physical activity, them to find joy in moving their body and being physically active. Because this is the kind of culture that we live in right now. From May 14th, a tweet that came along my timeline that men are less likely to wear face masks because they're not cool and a sign of weakness. This is kind of the message that maybe a lot of boys and men are hearing about their body, about not wanting to be weak and always wanting to be cool and not looking a certain way. That sort of appearance-focused culture is something that we're fighting against and will take a lot of internal and external work. So what can you do to support people? And I'm going to break this up briefly in a systemic framework and then an individual framework. Systemically, when we looked at the research on this topic, it said the health promotion campaign should target students who experience disordered eating, but also those who are in their support system and the on-campus service providers, because there's a help-seeking pathway that includes student groups, athletic facilities, and residents, especially around eating disorders. Individually, we really want to ask open-ended questions and keep the focus on what has us concerned. Questions like, what purpose does the eating disorder serve? Or what is it helping you cope with? Because that acknowledges that it has a function. And helping someone find motivating reasons for the person to get help and make positive health-related changes. These folks are perfectionists and are often really, really self-critical. So we have to remember to praise their strengths, even in reaching out, in wanting to do something about it, and noticing that something is wrong. And affirming their qualities and abilities that are unrelated to food or physical appearance is really important because they're much more than just that. And when their eating disorder gets tied in with their identity is when it starts to become really sticky. And borrowing from our folks in substance use and addiction, I really want to normalize that many people, when you first reach out, are going to be in the stage of pre-contemplation. They don't see the problem with their current behavior. And it's going to be really, really hard. You're going to feel really, really frustrated. And you have to remember to stay patient because keeping yourself as a safe person and identifying yourself as a safe person and having them surrounded by more people like you will help likely move them to contemplation to get them to think about change, because change is really, really scary. And relapse is really, really normal. If it's appropriate, you can respond by providing education. You can normalize their experience by letting them know what you learned today, that eating disorders are common. There's lots of reasons to feel ashamed or afraid. You can acknowledge their ambivalence. It almost sounds like you're battling yourself. It sounds like something about this isn't sitting right with you, but you're kind of torn. You can listen to their experiences and reinforce that it's not their fault. And if appropriate, you might have to do a safety check because we know that some clients, some students might need medical support if they're experiencing some of those physical symptoms like blackouts or dizziness or fainting. And we'll talk about how to refer accordingly. These are skills from relational interviewing, reflecting back discrepancies, but also supporting change. Asking questions like, how would you like things to change? What are things you've done before to make things better? And what's standing in the way of you taking these next steps? That can be really, really important in having the conversation move forward. So this brings us to refer. And this is sort of what eating disorder treatment looks like in Canada. And I try my best to kind of make this be easy for you all to see, and our team at NEDIC really focused on that when making this, but I imagine that it can also be really difficult. So I wanted to flip my screen share for a second to show you something on the website. So you all should be able to now see my screen on the NEDIC website. And if you see here, you can find the helpline link here. We're online on chat right now to start a chat. But if you hit get help, you'll go to our service provider directory. And here we're gonna walk you through what this can look like, and this is something anyone can do. We do this with clients on the helpline all the time, and you're always able to just give them that number. But I know many of you from an advocacy perspective, or it may be job relevant for you if you're a campus mental health professional, for example, to feel comfortable doing this, or a residence don. So let's say get started. You can enter your postal code. So I'm gonna enter mine. And obviously the screen's gonna be a little bit delayed, but the next question is, would you be open to online service, especially in the time of COVID-19? Especially for the next 12 months, it's gonna be really important to consider online services. We're gonna say here that we'd like to visit a location. Do you have cost requirements? So we know students in particular may only can look at things that are covered by provincial health insurance, things that are free, or things that are sliding scale or low cost. And then what's the age of the person needing support? Let's pick here the young adult age, just because I think that's mainly what you all see. But if you have an older student or a younger student, you can click those ages accordingly. And then you get to our terms, which is just us saying that we're not specifically recommending this one provider for you, that it's your responsibility to verify and ask questions to that service provider. But this is what's going to be close to you, sorted by distance to that postal code. So we see in our search that there's 109 results within 150 kilometers. That's a really broad range, so we can have even more filters here if you want. There's filters here for distance. Let's click something closer, like 25 kilometers. There's filters for different credentials. So let's say someone is specifically looking for dietitian-based support, food-based support, and a counselor or a social worker might not be able to provide that. Or they're specifically looking for a psychologist for insurance reasons. If they're looking for things that only require self-referral, because getting a medical appointment can be really hard. Or if they're looking for a certain treatment approach or treatment type. Other things include specific demographics. So if you are trying to find if a provider identified themselves as an LGBTQ positive provider, that can be here too. Or on languages, if you need something that can offer translation or something that's a space that's physically accessible. So let's apply a filter, and we get 62 results within 25 kilometers. And as you scroll through, you see the postal code in relation to distance. Some of these are provincially funded programs. And we can scroll. But let's click one, and I'll just click Fiona, for example. When you click through to her profile, you can see a little bit about this person, direct ways to contact them by phone or by email, that they take a self-referral, the kinds of age groups they see. Fiona offers sliding scale and online sessions and a free consultation. So all of that stuff might be nice if you're helping a student plan. You can also see what areas they're able to practice in. So Fiona can practice in Ontario and in Newfoundland, for example, which may be nice for those out of province students. So this service provider directory is something you are allowed to use and can be a really practical tool for you in your journey to try to connect people to eating disorder informed care. Because we know with a lack of training that can be really, really hard, and people can have negative experiences, and that may be difficult for you. You can go into Learn too, and here's where you can get the definitions for those eating disorder diagnoses that I skipped over. You can learn about additional definitions, like how BMI is used, different forms of therapy, what a social worker does versus what a dietitian does in treatment, and what out of province care looks like. So if you're supporting a student from another province. The last thing I'll show you is just resources. And this is just to say that You can search through, there's 214 different resources listed, that's always changing. And if you filter through in different ways, this is through article, you can find a guide for helping someone discuss their concerns with a primary care provider, for example. And you can download that and guide that with someone and walk them through that process as a way to communicate. So let me go back to PowerPoint to finish up. So this is a way to do referrals in a really easy, hopefully way for you on your campus. We also have some health promotion information. So this is like an LCD screen talking about our chat function. And you can visit medic.ch/spark, for example, for more posts like this for your campus that are tailored to social media, because that's something that's really important. And often we want you to know that you can use the helpline too. So it's not just for people with lived experience. Actually, 25% of people connecting with us are friends and family, 6% are educators, 1% are health professionals. You can contact us too if you're struggling and you're wondering about how to best support a student. You generally only have to wait for 28 seconds. Our chat is around 20 minutes. And this is really important that if you want to learn more, if you want that training for your campus counseling center, something that's specific, whether that's a pamphlet or a physical resource or a webinar tailored to your context, you're more than happy to contact us for that. I've ended the presentation with some resources for you. Some apps that we often share, like especially with students who have that kind of like technological literacy to use apps that may be helpful to recommend in supporting them with their eating disorder, but also some training and understanding resources that are ones from Canada, this one from CHIO, the CanPED resource, but also an online training for CBT for eating disorders that people can take. And then some specific resources for you to click through on your slides to get to the same pages that I was showing you during the presentation. During the pandemic especially, Sheena's Place located in Toronto and Body Brave located at Hamilton offer online support programming or online medical assessments for students who may be wondering, for anyone who's 17 plus, for Sheena's, and 18 plus, I think, for Body Brave. So that's it from my presentation. I will leave this slide up for the helpline, but I know that you all will have it, and I'll ask Perlin to come back for us to discuss any questions in the time that we have remaining. I know we started a little bit late, but I'm happy to stay as long as you would like me to stay.
No worries. Yeah, we have basically 2 minutes until 2. So we'd really encourage anyone, if you have any questions, quickly type them into the chat. Really quickly, we have 2 questions that have come up. The first one is, what supports would you like to see in high schools? Yeah, this is a really good question, especially from a prevention lens. And we're often out in school boards specifically doing not eating disorder work, but eating disorder risk factor work. So literacy. I think we need that in the province of Ontario, a systematic way to do eating disorder prevention for young people, starting from birth all the way to when they get to all of you. And I think that's something we're all happy to work on and have been working on in the communities. Banna in Windsor, for example, who did the French webinar for the center, is also doing that in their area. Awesome. Thanks, Ari. The next question is, are these NCHA results for all of Canada or BC? I think the ones you were using for all of Canada, right? All of Canada, yeah. Then that's taken straight from the NACHA website, which is good. Perfect. Okay, next question. Are the 30-minute webinars that you mentioned intended for staff training or for student audience? The ones I specifically mentioned were mainly for staff, just from a capacity building standpoint. But we've have history, especially for the institutions in the GTA, of doing things for student audiences, and especially for health promotion peers and wellness peers. That's something we're more than happy to arrange from a recognize, respond, refer, more feet on the ground style standpoint. Amazing. Okay, next question. What are the biggest barriers that prevent students from seeking help?
Yeah, I think this is really tough, and there's been a fair amount of research on this. And I think about barriers to help seeking more so in the way you think about barriers to help seeking for mental health in general. And I think for eating disorders, some of the specifics are really around some of the stigma that exists socially about food, weight, and shape. Maybe they not really realizing that you might be a safe person, that extra shame, especially for men, especially for people from underserved communities about it. Access to trained professionals is a really big worry too. I know from my experience on post-secondary campuses that we often refer out, and on our campuses we have to really contemplate ourselves. Do we feel like we want to get that training for that, or can we refer out at least using some of the things I showed you today in a community-informed way?
Amazing. Thank you, Ari. Okay, we probably have time for two more last questions. So first is, as an allied health professional, sometimes I find primary care providers who are concerned with a student's eating disorder will refer to services that doesn't necessarily appreciate the student's stage of change. Have you any advice or thoughts with how to respond to this? Just remind physicians of where their student is at with readiness.
Yeah, I think reflecting on readiness is something that's really, really important. We developed that primary care guide, and there's the one I showed you was specifically for people who are affected, but there's also one for primary care physicians that you can find in the resources section in the exact same place. You might want to share that guide with that person to let them know that primary care physicians are often really trying from a well-intentioned way, but might not have that education. And it's really wonderful that you're willing to provide that education for them, and that resource specifically might be helpful because they might be missing things or jumping too quickly, as opposed to how you're, I think, hearing about the concern.
Thank you, Ari. Last question. Well, actually, I lied. Maybe two more questions because these are really good questions. Great video at the beginning with lived experience. Is there a danger of triggering clients with having lived experience stories or videos?
Yeah, this is a really good question. I think I'm really mindful of it, and especially for folks who are younger than 17, it's something we really avoid talking about eating disorders specifically with them because there's evidence to point at that not being helpful. I think for all of you with university age populations, I think that's a determination, that a comfort that you all have to make, and especially if you have the time. Like, do you have the time to actually have a conversation with someone about the lived experience story if you send them a video or you watch it with them, as opposed to just like sending it in a message or sending it in an email, because that's a little bit more passive and then you might not be able to have that safety net around it. If you're sending a lived experience story, also send a local resource. So if you're in Newfoundland, send the Eating Disorder Foundation of Newfoundland and Labrador. If you're across the country anywhere, you can always send Genetic because our helpline is national. If you're in Quebec, ANAB in Quebec can provide that service. So for you in Ontario, some of the ones that I've mentioned, such as Sheena's Place, Body Brave, and us at Netic, send those resources with that story if you think it's an age-appropriate time to have that conversation. But if you're with them, I think it's more likely of it being safer as opposed to having it be a passive, like, send.
That's a great point. Okay, final question. I am an eating disorder therapist, and I notice oftentimes my clients' eating disorders take a turn in university. Any ideas why eating disorders sometimes get triggered or worsen in university settings?
And I think even the fact that the Center for Innovation in Campus Mental Health exists, I think points to the fact that many mental health experiences often get worse or triggered in university or college-based settings. I think it's because so much is going on. So much is changing. People are removed from their support. From a food and weight perspective, often students are having to cook or provide their food for the first time, or they finally have the freedom to potentially engage in a lifestyle that they feel like they want to live. All of that combined with academic stress and the pressure that people have, and people with eating disorders often being so self-critical and extra ambitious, means that pressure, I think, is paramount. So I'm not surprised to see concerns that maybe have already kind of been there in a biopsychosocial way earlier in life get exacerbated or worsened in university. an age of onset for eating disorders is generally earlier than some other mental health conditions like 10, 11, 12. So often I think it's rarer for it to start brand new in university, though it can happen. But I think just the setting in general is just a really ripe time as people consider really big questions like who they are and what their identity is and what do I want to do in life. And an eating disorder comes up as a way of coping with that uncertainty and that stress.
I'm so sorry. There's a fire alarm testing going on in my building. That's why there's a lot of background noise right now. Thank you so much for that. I think those are some really great points. Amazing presentation. And just for everyone who is still on the webinar, the slides and recording are going to be going out tomorrow. So I don't want to stay on too long because there's a lot going on in the background. But again, thank you so much, Ari, for the presentation. That was great. We've had lots of positive feedback here going on in the chat. Thank you for the presentation. And with that, everyone, I bid you an excellent rest of the day and stay tuned for that follow-up email with the links to the recording. All right. Take care.
Bye.